Welcome to the COE Fidelity Guidelines tutorial on inclusion. In this tutorial, we will be reviewing the first section of the COE Fidelity Guidelines titled Inclusion. We want you to be aware that the slides that we're using for this tutorial present the Fidelity Guidelines, along with additional resources to support guideline implementation. The written items on the slides themselves may be an overview of a guideline in some instances. So you should refer to the full Fidelity Guidelines document as opposed to the slides used in this tutorial if you need a reference of the written guidelines in their entirety. One of the guiding principles of the COE is that the COE will place primary focus on high-risk priority populations, such as pregnant women, individuals recently released from incarceration, individuals with intravenous drug use, individuals with acute or chronic homelessness or housing instability, individuals with a history of opioid overdose, and veterans. In alignment with this guiding principle, the inclusion criteria outline the ideal COE client. The ideal client to include in the COE should be 18 years and older, currently be enrolled or eligible for Medicaid coverage, meet the criteria for an opioid use disorder or OUD, and not be in sustained remission based on criteria in the most current version of the Diagnostic and Statistical Manual of Mental Disorders, or DSM. And finally, the ideal COE client should not be currently enrolled or have been enrolled in a substance use treatment program, including but not limited to medication for opioid use disorder treatment, MOUD, OBOT, OTP, or other outpatient providers for less than 30 days. There are some exceptions to the inclusion criteria. These include instances where the client has been enrolled in an MOUD program beyond 30 days, but shows reasonable harm, including a recent increase in substance use verified by 2 or more urine drug screens, recent overdose or other opioid-related medical event, or a treatment episode in an inpatient or residential level of care in the past 30 days, psychiatric or SUD treatment. If the client experiences a change or continuation of significant health-related social needs or social determinants of health needs, which could impact recovery, and those specific HRSN and SDOH needs to be identified in the client's chart, including what has changed that could risk the client's ability to avoid opioids. Or when the client is a transfer from another COE and continues to submit positive UDS and or have significant HRSN, SDOH needs. It is also important to note it is recommended that all clinical and HRSN SDOH needs be documented in the client chart to indicate the necessity for enrollment in COE services. The 30-day enrollment criteria apply to each COE individually. The clock does not start until the client enters services at your location. The exceptions to the inclusion criteria only apply when a new COE client are enrolled in the COE's Enhanced Care Management Services after 30 days or more in SUD treatment at a facility. For guidance on discharging, transitioning enrolled clients, refer to the Discharge or Transition section. What we're stressing with the timing notes here is that while COEs are expected to discuss other treatment providers clients may have engaged with in order to reduce duplication, the 30-day enrollment criteria doesn't apply to time that the client may have spent enrolled in another COE before beginning services at your COE. Instead, this is stressing that clients who have been in treatment at your COE for a long period of time should not be enrolled in COE unless there is evidence of reasonable harm as indicated previously. We also want to be clear that these are not discharge or transition criteria. For that criteria, refer to the final section of the Fidelity Guidelines. The rationale of COEs focusing on clients who have not been in treatment long-term or who have significant SDOH risks is so that the COE can allocate resources, expertise, and tailored interventions to the individuals who are most in need of them. This targeted approach aims to bridge gaps in care, reduce health disparities, and improve the overall health outcomes of vulnerable groups. Additionally, by addressing the specific challenges faced by high-risk populations, the COE can work towards fostering a more inclusive and compassionate healthcare system that meets the diverse needs of its clients. There are also guidelines for the managed care organizations, or MCOs, to monitor the COE program related to this inclusion criteria. The COE program was specifically designed for Medicaid beneficiaries. If managed care companies or primary contractors would like to expand coverage and payment to non-Medicaid clients, they may be permitted to do so. An additional indicator may be placed in REDCap to identify the clients not covered by Medicaid. This is not a requirement for monitoring, but a note about possible program expansion if desired. It is recommended that MCOs verify that the COE is using the outlined inclusion criteria and a social determinants of health screening tool to accurately determine medical and non-medical care management needs through the submission of service descriptions. Service description submission from the COEs may be recommended by the MCOs, as services may be enhanced or modified through continued quality improvement. MCOs can reach out to Peru for a copy of the service description that was submitted with their original application. MCOs can use claims data to assess the length of stay of clients in an MOUD program prior to enrolling in the COE. MCOs can also use claims data for assessing increased risk of clients who were enrolled after 30 days in an MOUD program. Claims that show increased risk include those that indicate the client was likely to experience harm because of their opioid use disorder, such as recent inpatient or residential treatment, emergency department encounters, or other crisis level of care provided to clients within the past 60 days before the first G-code was billed. The 60-day timeframe is the denominator to use in this type of analysis. Since MCOs are not required to collect real-time data and there is a claims lag, these instructions are for creating a cohort for analysis to assess for increased risk of clients who were enrolled after the 30-day timeframe, as specified in the exceptions section of the inclusion criteria. Behavioral health MCOs can monitor the length of stay of clients and OTPs to limit access to those who are likely stable in standard OTP services. The same for those in an OBOT. Urine drug screen data can also be used, which is available to both the behavioral health and physical health MCOs to assess clinical changes in clients leading to COE or enrollment. One positive UDS should not be used, as nearly all clients in an MOUD program will have a positive UDS for illicit substances in the year. Instead, MCOs can consider 2 to 3 consecutive positive UDS tests for enrollment, or a combination of a positive UDS screen and at least one crisis service in the past 60 days. Similar to the previous statement, the 60-day timeframe is for the cohort analysis. Because of the claims lag, real-time tracking of UDS patterns is not possible. Behavioral health MCOs can use the UDS results through chart reviews, while physical health MCOs can utilize claims data. Finally, MCOs will encourage the COEs to retain clients in medication management if they no longer meet case management criteria. This isn't necessarily a monitoring portion of the MCO guidelines related to inclusion, but an important note about program messaging, because clients who are stable in standard services may not need the enhanced care management that is offered through the COE, but may still be in need of MOUD. And access to medication management should not be limited, even if the client is no longer appropriate for COE services. Through chart review and/or review of COE's policies and procedures, MCOs can confirm the documentation of items related to inclusion outlined in the Fidelity Guidelines Documentation Guide. The documentation guidelines related to the inclusion section of the Fidelity Guidelines are documentation of client's age and/or year of birth. This should be documented in the client's chart and in REDCap. Documentation of client's MA number, or documentation that the client is uninsured but MA eligible, and that the COE is helping the client enroll in medical assistance. This should be documented in the client chart and then the quarterly COE crosswalk that all COEs are required to provide to DHS. Documentation of clients' opioid use disorder diagnosis, not in sustained remission based on DSM-5 criteria. This should be documented in the client's chart. Clients who are under 18 who do not have an OUD diagnosis or who do not have medical assistance should not be entered into REDCap. COE should also document any applicable exceptions to the inclusion criteria, if applicable, in the client's chart. Written procedure on how COE staff check with other COE providers in the area to ensure that there is no duplication of services, including a process for obtaining releases of information for care coordination purposes. Thank you for joining me for this tutorial about the inclusion section of the COE Fidelity Guidelines. Please contact your Peru TA provider with additional questions or requests for support.